invented in 1973, received FDA approval in 1975, and over the years they've improved tremendously. They're more reliable, they're coated with antibiotics. Surgeons are much better at putting the implants in. So yes, they've improved tremendously. So the success of the implants is extremely high. Now, like any procedure, you really want to seek a specialist. An implant is a little bit like the equivalent of root canal for a dentist. It's always better to see a specialist if you need a root canal rather than a general dentist. But you know, you want to see somebody who does a lot of implants, obviously. Obviously, we want the patient to be stable. Every patient gets evaluated by a cardiologist before an implant. And if A1C is totally out of whack, we will ask that patient to go see his physician and get that under control. But some patients, they can't get it below 8 or 7, and so we will do that, provided that their sugar is stable when they come in. So it's not a hard and fast rule. There have been studies that shown that the A1C doesn't correlate with the increased infection rate. Yes, there is. Especially with low testosterone, men with diabetes are often diagnosed with low testosterone, and definitely men who have poor control of their diabetes will have more erectile dysfunction. My take on this is really the carbohydrates is really the worst thing for us, and farming is really what brings all this diabetes and erectile dysfunction. If it wasn't for our diet, I would be out of business, basically. Our carbohydrate load is phenomenal. It's so phenomenal that we take it for granted. But the human body was not designed for this amount of carbohydrates. We're meat eaters, basically, and forage, and suddenly we have all this farming and all these plentiful carbohydrates around. I think that's much worse than alcohol, for example.
This is Dr. Baker. I also just wanted to add, per your question about the reversibility of erectile dysfunction, I think that in the setting of somebody coming in with poorly controlled diabetes and either neuropathy or erectile dysfunction or some other acute medical condition, there can be seen improvement in erectile dysfunction and things like neuropathy with better glycemic control and better control of the comorbidities of cholesterol and blood pressure. I think that there's a direct physical impact of that can relieve the vascular and nerve pressure, if you will, but also a improvement in the psychological health of these patients. So I do think that giving patients hope, as Benno had said, and part of that hope is that some of this can be reversible, and I think that we can focus on the comorbidities, and indeed, in many cases, we can see improvement in some of these issues. Well, I think that, again, what we want to think about with our patients is individuality. I think people respond to treatments and interventions very differently than another person, and I really think that instilling hope in that person that time will tell and the level of control will tell, but I think if we continue to screen these people aggressively, we'll see a lot of their symptoms improve with these types of interventions. Now, if they have advanced disease that is not reversible, that's certainly another story. But I think if we're thinking about starting stepwise, we start with counseling, we start with control of their comorbidities, we start with psychological endeavors to improve their psychological health, and then as was already said earlier by the panel, if they don't improve with that, we let them know what their options are, certainly one of which would be implantation.
Yeah, I think if you have different scenarios. You have, for example, a newly diagnosed diabetic, and then you treat the diabetes, and then the erectile function will improve. But if you have a patient that has a long-term diabetes and develop erectile dysfunction, it's unlikely that that situation is reversible. Even if you because really when you think about it, erectile dysfunction is not an early sign of endothelial dysfunction. It's actually the flesh has been damaged to the point where the erectile function no longer functions well. Yeah, insurance varies. Commercial insurance varies according to where you are located, and the patient, patients need to pre-certify. Your office needs to pre-certify for every insurance plan. For insurance that are with the government, you don't need to pre-certify. The insurances, Medicare, for example, will pay for implants. Obviously, every patient who gets an implant gets first treated with oral medications. We also try injections. We optimize their medical status. But you have to realize that at some point you have to say, well, how long are you going to want to try things that don't work? So at that point, you document everything in the chart that it was tried. It is not a treatment, it's not a first-line treatment. It's a treatment for advanced erectile dysfunction when basically oral therapy fails. And then you try to bridge with penile injections and other options. But it's pretty straightforward when you think about it as far as documentation.
I went into this whole thing thinking that, oh my gosh, this is going to be so hard with my insurance. I'm going to have to document everything. I thought I was going to have to dig up and try to find my old prescriptions for Viagra and Cialis and that crazy pump thing that you saw. I thought I was going to have to dig all those up, and so I was like really rearing for a fight, and I didn't have any of that. I did get my heart checked before, but I think my out-of-pocket costs were in the hundreds of dollars. And I expected that this was going to be like a legal proceeding, that I was going to have to prove that everything else had failed. But for me anyways, and I don't have like congressional insurance. I don't have this crazy insurance. I have normal commercial insurance like the doctor said. I had no issue with the insurance. Yeah, I think there is, and I know there's plenty of information on edcure.org where you can hear from men like me who have actually had this. They're not actors. And so I think that's a really important thing too, is if you bring it up, you need to know where to send men. And as the doctor said, you want to send them to prosthetic urologists. You don't want to send them to a urologist who may not be comfortable talking about an implant, who doesn't do them, because if it's presented the wrong way, it will scare men. I mean, it will scare your patients if an implant, which as the doctor said, is not a frontline treatment. If it's not presented properly and in the context of hope, and that, hey, your erectile dysfunction is not something that you're going to die with, you can actually enjoy sex again and it's going to feel natural and you can do this, then I think it's going to scare them away and they may not want to do it.
I think once they fail oral therapy, then they have advanced erectile dysfunction. And the testosterone replacement, and Dr. Baker can talk more about that. I'm not very much in favor. I don't really believe in low testosterone levels. I think it's a myth, really. Testosterone is either abnormal or normal. And once you start replacing testosterone, they stop making their own. So you have to deal with that, especially if it's a younger man who wants to have procreate in the future. It'll suppress their own fertility. So testosterone is really mostly for libido as well. It doesn't impact erectile function that much. So once they have failed oral therapy, I would at that point refer him to a urologist who is interested in treating men with erectile dysfunction. And then their options will be to either do the injections for a while, the penile injections. Most men hate that, and they won't, especially younger diabetic males, they'll won't last very long on injections.
I did,
So,
I did the injections, and when Dr. Eid was describing the patient's response to that, it just brought back like shivers. I mean, and remember, I'm on an insulin pump now. I'm on an insulin pump, but remember, I had diabetes before my insulin pump. I used to take shots all the time. I took like 10 shots a day in some cases. So I'm okay with needles, and I hated it. I mean, I was glad that it worked, but it's not the most spontaneous thing.
well, thank you so much for coming tonight. It's been great to have you here.